Okay, so how this Q&A works is you guys can submit your questions through the Q&A tab, or you can raise your hand, or you can ask in the chat. If you would like to do it anonymously, I do recommend doing it in the Q&A, and we will get to your questions one by one. Are we ready, Dr. Boster?
Let's go for it.
All right. First question, can you please explain your take on Kesimpta? I'm nervous about starting soon. What can I expect?
Absolutely. So Kesimpta, the generic name is ufatumumab. I don't make up these names, but isn't that kind of fun? Ufatumumab. It sounds neat. Kesimpta is a highly effective B-cell depleting drug. It's in the same family as Ocrevus, ocrelizumab, and rituximab, and Bruemvi, which is the newest drug to join the armamentarium. That's ublituximab. And all of those medicines are high efficacy medicines. They're very, very effective B-cell depleters. The biggest difference between all the medicines in Kesimpta is not infused in the vein. It's given as a self-injection through a shot that you give yourself once a month. Now, there have been no head-to-head comparisons looking at Kesimpta against Rituxan or Kesimpta against Ocrevus or something like that. But I would say that the drugs are probably much more similar than dissimilar. They sit on the same high efficacy shelf.
All right. Can or does multiple sclerosis slow the digestive tract? And if so, how does it present?
That's a fascinating question. And it's got a fascinating answer. Yes, people impacted by MS have slowed gut motility, believe it or not. And it's not uncommon that my patients will either describe significant constipation or sort of like an IBS scenario, irritable bowel syndrome, where they'll have some constipation, then diarrhea, the constipation and diarrhea. And it gets even weirder when you look at what's called the microbiome. So in our gut, our entire gut lining is lined with colonies of bacteria, particularly in the colon at the end of the gut. And those bacteria, they do more than just process our foods. They actually interact with other organ systems, including this organ system, believe it or not, and the immune system. And in the setting of MS, it turns out, the populations of bacteria are weird. They're not the right kinds. The term is dysbiosis. These are like Scrabble words. And so there's a growing discussion about whether or not we could manipulate the microbiome by taking probiotics and prebiotic fibers and whatnot to change the population, not just to improve gut health, but even to maybe slow MS one day. It's really interesting stuff.
Have you seen any improvement in trigeminal neuralgia due to MS if treated with surgery?
Yeah, many times. So trigeminal neuralgia is a pain which is described as one of the worst pains that a human being can experience. And it's unfortunately associated with a high risk of suicide because of the severity of the pain. Now, the trigeminal nerve is the nerve that provides sensation to your face. So it kind of comes out of your skull over here, and there's a branch that goes up to the top. That's called the first branch. And then the second one is here at the cheek, and then there's one down here. So there's 3 branches. And if the nerve gets pinched, it can send a pain message. It's an excruciating, lancinating, electrical type pain in one of those areas. Now, people can develop trigeminal neuralgia, but people impacted by MS are 14 times more likely to experience trigeminal neuralgia. And the reason is because not only are they at risk of having the nerve pinched where it comes out of the skull, but if the nucleus, the part of the brain that drives the nerve, is affected, they can also manifest trigeminal neuralgia. Now, the way that we treat this terrible, painful condition is to use medicines to stabilize the cell membrane. So we oftentimes use medicines that were invented for seizures, things like gabapentin, Neurontin, Lyrica, pregabalin. And sometimes those can control the trigeminal neuralgia, but sometimes that's not enough. And there are fortunately many different kinds of surgeries that can be done. There can be gamma knife radiation, there can be balloon dilation. There's a host of procedures that pain anesthesiologists and functional neurosurgeons can do, which is a godsend. And so if you are listening to me and you have trigeminal neuralgia and the medical regimen's not cutting it, you most certainly should be evaluated by a surgeon.
James is asking, I just had Evishield shot and was told I should get the newest vaccine now. Your thoughts on it? I do not know if I need another COVID. I know not another COVID question.
It's okay. So there's still a global viral pandemic, and we still need to keep you safe and treat your disease. So it's a very, very appropriate question. And I'm wondering if the folks that are hosting, if you could leave the question up until the end of my answer, because sometimes in the middle of my answer, I forget and I'll reread it.
Yes.
It'll just help me kind of jog my memory. So I think this question was, I took Evusheld. What about getting the vaccine? And those two things are, they can happen in parallel. And I would recommend that you do both. Now, I can't give you specific advice, James, because I don't have enough information about you. But speaking in generalities, the two therapies are complementary or synergistic. Evusheld is a prophylactic medicine. It's actually two medicines that floats around in the human body. And if you come in contact with the coronavirus, it attacks it. And so to me, it's like hiring like these two giant men that wear black trench coats and they don't talk or smile and they just stand behind you and they're real tough. And if a bad guy comes up, they jump in front of you and they beat him up and then they just jump back behind you like bodyguards. That's kind of how I think of Evusheld. Now, a vaccine is different. A vaccine is training your immune system to build an army specifically against the infection. And it's different than the Evusheld. And so when you do both, you really bring two different avenues to bear. Now, many of my patients are immunosuppressed at my hand. I've given them medicines that suppress their immune response. And so if they were to contract an infection like COVID, it could be more severe. So I want those patients to be vaccinated and I want them to have Evusheld both.
Carol is asking, why is it so hard to diagnose MS and is transverse myelitis the same?
So two excellent questions. So multiple sclerosis is a situation where your immune system attacks the central nervous system, but the central nervous system is huge. Like it's your eyes and your nerves that run your eyes, your entire brain, and then your entire spinal cord. Like it's a lot. And so the attacks occur random of sorts, right? So one person can present with, I can't see out of my eye because I have a optic neuritis. Another person with MS can present with a transverse myelitis where they can't feel from their legs down. So you have one person that's blind in the eye. You have another person that can't move their legs or feel their legs. And I'm telling you, they have the same disease. That's weird. And so the way that we diagnose MS is through a series of steps. And it's not a feeling. It's not like a maybe smells like MS. That's not the way this works. There's very, very clear criteria that are driven by statistics. So it's scientifically driven. And there are 5 elements to an MS diagnosis. The first is the story. So that's like what the patient tells me. And I'm listening for elements that are consistent with an MS attack or progression of disability. So that's the story. Then I examine the patient and I'm looking for evidence on exam that supports the story. So for example, if you tell me that you had some problems with your balance, I expect to see some balance problems when I do balance testing, right? So then the third thing that we look at is the MRIs. And we look for certain features on the MRI that are suggestive of multiple sclerosis. And again, it's not it kind of feels like it. There's actually like criteria, like certain numbers of spots in different locations. Number 4 is spinal fluid. And you're not required to have spinal fluid to make the diagnosis, but sometimes the spinal fluid can cinch it for us. And number 5 is, hey, prove it's nothing else. So there's a lot of steps to confirm an MS diagnosis properly. Now, the second question is transverse myelitis the same? No, it's not. So if you look at the word myelitis, M-Y-E-L, is the first part is myelo, which is Greek for spinal cord. right? Itis means inflammation. So myelitis is inflammation of the spinal cord. Transverse means it affects both sides of the spinal cord, but it doesn't have to be equal. So a transverse myelitis is when you have an inflammation of the spinal cord that makes it not work very well. And many, many things can cause a transverse myelitis. So when someone presents with, my legs are numb, I can't move them very well, my bowel, bladder, and my personal private parts don't work very well, and I'm concerned on exam, they have a transverse myelitis, I get imaging of their spinal cord, and I can see if they have a lesion in their cord. Now, when someone has a transverse myelitis, a third of the time, it's called idiopathic, which is a doctor word for I got no clue why that happened, and it never comes back. So 1/3 of the time when you have a transverse myelitis, it's a one-hit wonder. 2/3 of the time, the transverse myelitis is the first event that goes on to become something else, like multiple sclerosis. So when someone presents with transverse myelitis, we don't just image their spine, we image their brain because we're looking for lesions. And we might do lumbar punctures and other testing to try to clarify if the transverse myelitis is part of a bigger picture. Good question.
Thank you. We have somebody raising their hand, Karen. I'm going to allow her to talk.
Hey, Karen.
Karen, can you hear us?
Yes, I can. Hi, doctor. Thank you.
My pleasure. How are you this evening?
I'm doing great. Thanks for asking. A year ago, the paper came out from Harvard that did the study linking Epstein-Barr virus to, that has to be I can't put it together, but that has to be the reason you'll eventually get MS. If everything else is equal, if you don't have that, you wouldn't get it, is what the speculation is, correct? And I had that at 16, and I developed a very bad case of glandular fever or mononucleosis that went on for a couple of months.
Yuck.
As the study has gone, do you have, since so many people have had Epstein-Barr, is it also needed to result in mononucleosis in order to move on to MS, or just get the virus is all that was needed? Sorry to stumble on the words there.
No, you did fantastic. And so for those of you that are not as familiar, Karen is talking about a really big investigation that was published a year ago. And it looked at 10 million Americans. So that's a very large number, 10 million. And it looked at the incidence of Epstein-Barr positivity, so you can look and see if somebody has been exposed to the Epstein-Barr virus. And what they found was 95% of the 10 million people had been exposed to Epstein-Barr. So 95%, which means it's a very good virus that it infected 95% of the population. Now, amongst the 10 million, I think there was like 801 people with MS. So of the 10 million people that they studied, 800 of them had multiple sclerosis. And of the people with MS, all of them but one had been exposed to Epstein-Barr. And so that's basically like 100% of the MS patients had Epstein-Barr compared to 95% of the total population. And at first blush, you might say, well, gosh, that's only a 5% difference. But when you're dealing with numbers that big, it's extremely statistically significant. And what it did is it didn't really give us any new information. We already knew that Epstein-Barr was probably involved. It just kind of cinched it for us in its really, really robust evidence supporting the idea that probably getting EBV mono is part of the process for you to get MS. Now, the second part of your question was, do you actually have to have the infection mononucleosis? Like, do you have to be sick with glandular fever? So when you come in contact with EBV, some people might get EBV and not really manifest too much of anything. Other people get mono, the kissing flu, where you're homesick from school for a couple months, really, really tired on the couch. And I don't think that we know the answer as to whether or not you have to manifest the illness mononucleosis in order to go on to get MS. If I was to guess, I don't think you have to have the clinical illness. It's probably adequate that your immune system sees EBV virus and fights it. But that's conjecture on my part. That's a great question. Thank you, Karen.
Anonymous question. How can I get CBD cream to help with my neuropathy instead of gabapentin?
So here starts the disclaimers, right? So I'm not giving you medical advice, and you have to talk to your clinician about what's right for you. And I'm not telling you to stop your medicine without talking to your doctor. Okay, so now I'm not going to go to jail. So CBD is a cannabinoid. So let me explain what the hey that is. All right, so let's take 2 steps back. So many of you listening to me are super familiar with the various organ systems of the body, like the immune system that fights off bad guys, or the circulatory system that moves blood and oxygen through your body, right? But there's an organ system in the body that most adults don't know about. It's called the endocannabinoid system. All right, I didn't make this up. And the endocannabinoid system are a bunch of receptors throughout your body. And when they're stimulated, they modulate certain functions like inflammation and pain and metabolism. Now, your body makes its own endocannabinoids. So your body makes endocannabinoids that bind to this endocannabinoid system. So you may have heard of this plant called cannabis. So the cannabis plant grows and it makes a bunch of chemicals called cannabinoids. And the 2 most common cannabinoids that the cannabis plant makes is a cannabinoid called THC and another one called CBD. And when you ingest cannabis, you're ingesting all these different chemicals, including THC and CBD. Now, scientists can extract the CBD by itself or extract the THC by itself. And that's actually what's happened. And so there's a process by which you can pull just the CBD out of the cannabis. Now, THC and CBD bind to different receptors and they do very different things. So THC can make you feel medicated, right? So that's the new term for high. Or it can make you feel altered because it's psychoactive. It binds to CB1 receptors in the brain. CBD, unlike THC, has no psychoactive properties. It does not bind to the same receptors in the brain, and it does not make you feel impaired. So you could like take a bunch of CBD and take a math test and do just fine, and you wouldn't be like impaired. So that's what CBD is. And CBD, interestingly, helps with pain, believe it or not. It's really interesting. It actually modulates pain responses. And so there's not very much research on CBD. The research is pretty poor. Anecdotally, I can tell you that I have had some rock star successes in clinic prescribing or recommending that patients get CBD cream and they can rub it on topically. So for those of you that are familiar with my YouTube channel, I made a video last Thursday on CBD cream where I explain how it works and why it works. And so there's a lot of different places where you can get CBD cream. The one thing that you want to keep in mind is because CBD is not regulated by the FDA, the person making it is not required to tell you the truth. So when you go to the Kroger's and you see a bottle of CBD, it's not guaranteed that it actually has CBD in it. And so before I switch to a different question, let me share with you how you can find high quality CBD, right? So number 1, you want it to be organically grown. Number 2, you want it to be CO2 extracted, organically grown, CO2 extracted. Number 3, you want the manufacturing plant to use, it's called good manufacturing practices. And so they can like have a stamp, good manufacturing practices. The next thing is you want it to be independently third-party tested. So you want not the manufacturer to test it, but you want some other person to come in and test it. And what they're testing for is to make sure it doesn't have like heavy metals and arsenic and like other stuff. And then you want to make sure that you have access to the certificate of authenticity. So the certificate of authenticity is the scientific document that shows you what's actually in the CBD. And so I recently went through a process of curating some really high-end CBD, and those are the things that I looked for to be able to offer it to my patients. That was a great question, and thank you for asking it.
I just want to, before I continue asking questions, I see 2 people have raised their hands and we will get to you. Just please stay patient. Ben is asking, I'm on Ocrevus for primary progressive MS. How are other B cell depleters different?
The biggest difference, Ben, is that they have not tested their drugs in primary progressive MS. So the manufacturer Genentech ran a clinical trial that I participated in called the Oratorio trial, where we took people in the United States with PPMS like yourself, and we either gave them dummy drug or Ocrevus. And what we demonstrated was Ocrevus slowed progression of disability by 24% and slowed brain volume loss by 20%. It was really phenomenal. Now, that was the first time in the history of Earth that we demonstrated statistically significant fashion that we could slow PPMS. And it was done to the satisfaction of the FDA, which is why it's approved for PPMS in the United States, and by the EMA, which is why it's approved for use in parts of Europe. Now, the other B cell depleters don't have data like that. Rituximab has an old trial called the Olympus trial, and the Olympus trial was in PPMS, and it was not a successful trial. Kesimpta has never done studies in progressive MS, and so we don't have that kind of data. Ublituximab does not have data in progressive MS, and so that's the reason.
Okay. Anonymous question. If an MRI didn't show signs of MS, can or should you try to get further tests? And if so, what tests?
So remember when we were talking about like, how do you diagnose MS? And I said there's 5 things. So you can imagine a scenario where the human being has a story that sounds like multiple sclerosis, right? So you're listening to it going, yeah, that sounds like MS. And maybe you examine them and you either do or you don't see stuff on exam. And then you get the MRI and the MRI looks clean. So it's very hard, near impossible, to have MS in the modern era with normal MRIs. And I would say that with a high quality MRI, if it's normal, then that doesn't allow you to confirm the diagnosis at all. And so what would you do in that instance? Well, it really depends on a bunch of factors. If there's a high enough suspicion, then the better part of valor would be to repeat the MRIs every 6 months for maybe 2 years, and then maybe once a year for the next 3 years. Why? Because the best test available, the best biomarker available is the MRI. And so if we think that there's a suspicion, we may monitor people serially over time because, as I like to tell my patients, you can't hide your spots on my scanner. I'll see them. And so if there's spots that evolve, I'll pick them up. And that would probably be the number 1 test that I would want to get in follow-up. That and a serial neurological examination by the neurologist.
Thank you. Okay, David, I'm going to unmute you. Can you hear us?
Hello. Hello, Dr. Boster.
How are you, good sir?
I'm doing well.
Excellent.
My name is David, and I am from the Bahamas.
Wow, I'm jealous.
I'm doing this. But I have been living with MS for 26 years.
Mm-hmm.
I recently did a blood work, and my uric acid was low. So my question is, why? I researched and I saw a lot of MS patients have low uric acid, but I want to know why my own is low and what could be done to improve it.
Typically, David, once per seminar, I'm asked a question I don't know the answer to. And you asked the question tonight that I don't know the answer to. So I will share with you that I am not familiar with any data linking low uric acid with MS. But again, I don't want to speak out of school. So instead, you now know what I'll be looking up as soon as we're off the line tonight. I'll be looking up in PubMed uric acid and MS because I don't like to be stumped. So thank you for asking that question.
Not a problem.
Marmon from Facebook is asking, does MS cause tinnitus? If so, are there any treatments for it?
So tinnitus is when you have a ringing in your ears, because it would be way too easy to say ringing in your ears. So we have to use a medical term, tinnitus or tinnitus. And MS can cause tinnitus, and it's extremely frustrating to treat. It's very, very annoying. And what people oftentimes notice is at night, when the home is quiet and the kids are not screaming and the dog is not barking, it's quiet. And so they can hear in their ear, and it's really, really disturbing. Now, sometimes we can use benzodiazepines, like medicines in the Valium family, to dampen that, but with side effects. Sometimes we can use other tools, like, for example, I'll have people turn on white noise, because if their ear can hear white noise, it dampens the buzzing. Tinnitus is very difficult to treat, and you may end up getting an audiologist involved to help you.
Thank you. Anonymous question. I'm 2 infusions in with Tisabri, sorry, and have had a good experience so far. However, I still feel weak, dizzy, etc. My doctor doesn't seem to think what I'm feeling is due to MS or the medication, but I have a hard time differentiating.
That's an excellent question. And I think it speaks to the need to clarify the different kinds of treatments, right? Because it is confusing. So let's start by saying this. If you are on a birth control pill and you have 3 children, right? Just because you start birth control, you still have 3 children. The 3 children don't disappear when you start the birth control, right? Because the children occurred before the birth control. If you're taking birth control with 3 kids, it's to prevent an unplanned 4th child, right? And my joke is, if you want to remember while you're on birth control, go hang out with your 3 kids, right? I'm teasing. In this example, the birth control doesn't remove something that already happened. It prevents something bad from happening in the future. Tisabri is a birth control pill against MS attacks. It prevents new MS attacks. Tisabri is a birth control pill against future MS brain damage. But Tisabri cannot give you back the stuff that you've already lost. So if you have neurological symptoms from MS and you start on disease-modifying therapy like Tisabri, I would not expect them to go away. And in fact, I want you to recognize that the reason you take Tisabri is because you don't like those symptoms and you don't want any more, right? And so when we take care of someone with MS, there are 3 avenues of treatment. Treating an MS attack when it occurs, which is not the tenor of this conversation, slowing the disease down, and treating symptoms. Now, woe is the neurologist that just slows the disease down and doesn't take care of the symptoms. Because if I give you a Tisabri and you don't have attacks, but you're miserable because you have spasticity and depression and fatigue that are untreated, I'm not doing my best job. In order to do my best job, I have to give you Tisabri to make you not have attacks. That's the birth control pill against future events. Then I need to use lotions and potions to improve the quality of your life by improving the fatigue and improving the spasticity and taking care of the depression, etc.
Anonymous question. How concerned about COVID, flu, RSV, etc. do we need to be if we're taking Kesimpta? Should I avoid going out to restaurants?
So that question doesn't provide enough information for me to give an answer. So there are so many variables that we can now consider. For example, are you vaccinated? Are you boosted? Have you had COVID? Have you mounted a response? Are you wearing a mask? Are you on Evusheld? Have you had monoclonal antibodies? What is the disease modifying therapy that you're taking presently, and does it suppress your immune response? Which part of the country do you live in? How crowded is the restaurant that you're going in? All of those things factor into the discussion. Are you someone that has other risk factors? Are you a gentleman? Are you over the age of 60? Do you have undertreated comorbid conditions like asthma, COPD, congestive heart failure, coronary artery disease, morbid obesity? So as you can see, there's many, many different factors that we have to bring to bear in order to answer that question.
Next question. Anonymous is asking, is Gilenya as effective as other B-cell depleting drugs? And how long do patients typically stay on it?
So Gilenya in groups is not as effective as the B cell depleters. It's not. Now, in an individual human, it either works or it doesn't work. And as far as how long do you stay on a drug? Well, you typically stay on it. I keep a patient on a drug unless 5 things happen. So they have an attack on the drug. That's not okay with me. They have a new MRI spot on the drug. That's not okay with me. All right. They are having changes on their neurological examination. They're progressing and I need to check into that. That's not okay with me. The drug is no longer tolerated or the drug is no longer safe. So if those things happen, then we're going to cut bait. But I saw 2 patients today that are on Gilenya. I call them legacy patients because they've been on Gilenya since 2010. And there are drugs that in groups of people are way better, but not in them. In them, they're doing amazing. And so I'm not going to change them off that drug. If they had new disease activity, we would escalate it to something else.
Thank you. Donna from Facebook is asking, what is the best thing to do when probiotics don't really help? And you also have gastroparesis and have trouble with bowel movements and severe bloating.
So we have to define first what we're trying to help with, right? So I'm hearing about gastroparesis, slowed gut motility. I'm hearing about bloating. And so we would need to know several things. So I would be curious if we were adding fiber in the diet. I would be curious how often we're moving our bowels. There's a bunch of things I would need to look through the medicines. I think in that scenario where you started some probiotics, I think that's great, but I would really look at like the rest of your nutrition. Are you eating processed foods a lot? Are you eating really sugary foods and fatty foods? And what is your water intake like? Like there's a bunch of other things that we need to be thinking about, which could impact gut health. Now, you most certainly can bring this up to your primary care or your internist, and there are medicines that can help with gut motility. Things like erythromycin, or, they have these newer medicines, Linzess and various things that can really help with gut motility.
Margie is asking, does fasting help with MS?
So I smile, Margie, because some of you who follow me on social media know that I've fallen in love with intermittent fasting. And I personally have lost 40 pounds with intermittent fasting. And I've made many, many YouTube videos. I'm a very staunch believer that intermittent fasting might be one of the very best styles of weight loss for people impacted by MS. I have a bunch of YouTube videos on the topic. One of them is called Wheelchair Weight Loss. I'll tell you a story I'm so excited about. A young man, early 30s, devastating MS, can't move his legs or one of his arms. He can barely move one arm. So he's very limited in his mobility. And as you can imagine, he gained a lot of weight because he can't really move and he can't really diet because if he doesn't eat, then his metabolism just slows down. So he started doing intermittent fasting and he lost 35 pounds. He looks amazing. He's doing great. And so I really think that intermittent fasting is a very, very powerful tool. I recommend it to my patients ubiquitously in clinic. And I can say with excitement in my voice that it does amazing things to energy levels.
I'm going to give, I'm so sorry if I mispronounce your name, Maciel, permission to talk so she can ask her question. Can you hear us, Maciel?
Yes, yes, I can. Thank you. Hi everyone.
Howdy.
I wanted to ask, so relapsing remitting MS, can it proceed to becoming primary progressive MS?
No. So doctors love making up labels. Like we just think that's the best thing ever. And neurologists are amongst the worst at it. We just we label everything, right? And so the terminology is very confusing. Primary progressive MS means that you started to have progression without attacks from the get-go. Primarily, you primarily started out with progression. So nothing evolves into primary progressive MS. If you have ever suffered a relapse ever in the history of your disease, then you don't likely have primary progressive MS. You likely have a relapsing form of MS because you've had a relapse. And so sometimes people that have relapsing MS, after around 15 years, their disease can change and they can start to have progression without attacks. And we sometimes refer to that as secondary progressive MS. It's secondary progressive because it's secondary to relapsing MS. So first they had relapsing MS, and then secondarily they had progression. So hence the term secondary progressive. Super confusing.
I agree with that. Anonymous question. I am a MS patient. I take the medicine, I'm going to butcher this, Abagio,
Abagio.
and my condition is fine. I live like a normal person, but I have one problem. When I sleep at night, I don't feel and completely lose sensation, and I have involuntary urination frequently. Went to a urologist. He told me there's no solution except to withhold fluids at 6 p.m. I want to live like a normal person, but what does MS have to do with this? And how can I find a solution to this? Do
Yep.
you advise? I'm sorry, go ahead. There's more.
When, she just said, do you advise perform an operation on the bladder, or is it related to MS? Okay, so that's a great question. And it's a really good discussion. So thank you very much for sharing that. So people impacted by MS very frequently can have their bladder messed with. And there are three kinds of bladder problems that we see in MS. The first is called overactive bladder. And it's when the bladder, which is a bag that holds urine, tightens down. It spasms down to the size of like a racquetball, right? So you drink half a Coca-Cola and your bladder's full, sister. You don't have any more storage capacity. And so overactive bladder presents itself as frequency. So you're getting up way too often to go to the bathroom, multiple times a dinner. Nocturia, which means I'm getting up more than 3 times a night to go pee-pee. Urgency, meaning move because I'm going to pee right now. If you don't move, I'm going to pee anyways, right? And then sometimes incontinence because you can't make it in time. So that's a problem that MS can cause, and it's called overactive bladder. Now, there's a completely separate bladder problem that you can have in MS, and that's called urinary retention. It has nothing to do with the size of the bladder. It has to do with the outflow tract. So from the bladder is the urethra, and the urethra is where the urine leaves to go into the toilet. Okay, so that's the tube that goes out of your body. And sometimes in MS, the urethra is tight, like a swizzle straw. So you got all this urine in a bag and you're trying to push it through a swizzle straw, and it doesn't go very well. And you sit there and you push on your bladder and you stand up and you sit back down and you dribble and you can't get started. And sometimes it fills up with urine so much that you just lose all your water, right? Now, there's a third problem that people with MS can have where they have both the first and the second problem, and that's called dyssynergy. Now, it sounds like you have an overactive bladder, right? And if you go to bed, then you can wet yourself at night. And what the urologist is recommending is actually very smart. And I want to explain why they're recommending it. This has nothing to do with MS. When you consume a liquid like this, you make urine for the next 6 hours. So if you drink a glass of water at 10 p.m., 11, 12, 1, 2, 3, 4 a.m., you will make urine until 4 a.m. And if you have an overactive bladder, you're not going to last. It's not going to happen. So if you instead stop drinking fluids after dinner, then let's say that's like 6 p.m., you're going to stop making urine sooner in the evening. And so it's going to cut down on your little bladder filling full of urine and then you having an oh no moment. And so that can be really, really helpful. Now, there's a host of other things that can be done to prevent you from being wet at night. Some of my patients will do an intermittent self-catheterization where they go in the bathroom and they try to empty their bladder, and then they put a catheter in their urethra, they drain their bladder, they pull the catheter out, and then they know they're going to not be wet at night because there's no bladder full of urine. It's awesome. There are medicines that we can take to expand the bladder to a normal size. There is Botox procedures that can be done to expand the bladder to a normal size. There's all kinds of lotions and potions. So I vehemently disagree with the doctor that said there's nothing that can be done. That's completely false. There's lots of things that can be done. And so I would go back to your doctor and say, I don't want to wet the bed, so help me. And if you can't, send me to someone who can.
Elisa is asking, sometimes when my leg is bent, my knee bounces quickly, uncontrollably until I unbend the leg. Why does this happen? And is this something only for MS patients?
So you're beautifully describing something called a spasm. Okay, so I'm going to use my arm as an example, and we'll see if, so you can see my arm. So when I want to bring my hand to my head, my biceps muscle has to contract. Okay, it has to get shorter. And there's a tendon at the end of my biceps muscle. Now, if I smack the tendon with a reflex hammer, it stretches the tendon, and that sends a message to my spinal cord. It says, hey, somebody just stretched your tendon. And it sends a message back to the muscle to contract. And so when I tap the reflex, I may get a bounce. Right? That's a reflex. So you've seen the neurologist, like they'll smack your knee and your knee will move. So that's a reflex. A spasm is where something triggers that and there's a positive feedback. It doesn't stop. So it starts and the movement of your arm triggers it to happen again. So then you have a bouncing. So it's like a reflex that doesn't quit. And it's a reflection of damage to the brain or spinal cord. So the brain and the spinal cord are called the upper motor neurons. All right. And so spasticity is something that happens with upper motor neuron damage. So it's not just MS. So multiple sclerosis, a stroke, traumatic brain injury, spinal cord injury, cerebral palsy, anything that beats up on the brain and spinal cord can cause spasticity. About 70% of people with MS have spasticity.
Thank you. Brianna's asking, I've got a job that works with the general public and have wanted to stay on DMTs that have the least amount of compromising my immune system. I've just begun
Tecfidera.
Thank you. But I know it takes a number of months to know if it's working. What other medications have least amount of immune compromising?
So when I find a drug for someone, when I work with someone to put them on a drug, I want to put them on the most effective drug they're comfortable taking. The most effective drug they're comfortable taking. And I crafted that sentence very carefully. And I think Brianna gives a good example. So she, in this example, is not interested in being on the most effective drug. What's driving her decision is risk, which it's her body. She's allowed, right? And so her rationale is, I want to be on the least risky drug as it relates to suppressing my immune response. And I just bring that up because that's not the way that I approach it, which does not make me right. It's your body. And so I really like this question. And I think that we should honor your request. If your goal is to go on a medicine that is less likely to affect the immune system, we certainly can serve that up. And so what we'll be looking for with this kind of medicine is something that's immunomodulatory, not immunosuppressive. There's really two major mechanisms when treating MS. You can suppress the immune response or you can tweak it so it doesn't misbehave, right? And the immunosuppressive drugs are going to have a much bigger impact on your immune system, immune compromise, as you've put it, as compared to the immunomodulatory drugs. So what are the immunomodulatory drugs? Glutamate acetate Copaxone, all the interferon beta products. So that's Extavia, Betaseron, Rebif, Plegridy, Avonex, all those. Tecfidera, the medicine you're on, which is dimethyl fumarate, Vumerity, which is diroximel fumarate, and Aubagio, which is teriflutamide. All of those drugs I consider to be immunomodulatory. Now, some people might consider Gilenya and its cousins to be immunomodulatory, but I think it's a functional immunosuppressant, so I would not include it in that list.
Anonymous question, what are the best resources for vitamin supplements and nutrition best practices for MS? I'm looking to supplement and improve my habits while continuing with my medical treatment plan.
So I don't know where the undisputed heavyweight best location is. I can share what I've done for my patients, which doesn't mean it's the best. It's just what I've created for my patients. So I've curated a line of high quality medical grade supplements, and I started a product line called Refresh Ohio. And so my immediate response is, well, the best vitamins are found at Refresh Ohio, because that's the ones that we've sourced and that we're making available. But that's not really the intention of my response. I think I would rather point out that trying to figure out nutrition is tricky, and most neurologists, particularly American trained neurologists, do not have a very deep understanding of nutrition. It's just not something that we're taught very much about in medical school, and yet it's really, really, really important. A resource that I would encourage you to check out is my YouTube channel. I have a YouTube playlist on nutrition with 25 some videos where I share my opinions about nutrition and best practices. Now, supplements are part of that story. It is not the primary focus of nutrition. The primary focus of nutrition, of course, has to do with food choices and food quality and adequate hydration. And I truly believe that supplements are just that. They should supplement a healthy diet. And yet I think that most Americans don't have an amazing diet, and I think there's plenty of room for supplementation. So definitely check those videos out and let me know what you think.
Anonymous question. I have the most severe cog fog. It literally feels like half of my brain isn't working. My head feels heavy. I zone out. Is this normal? I had COVID a few months ago and it's gotten so much worse since then. What are your thoughts?
So cog fog is extremely common in MS, and it's an invisible symptom which takes people out of work. So people leave the workforce not because they can't walk. People leave the workforce because they can't process. And so it's an evil, insidious, invisible symptom. It's a very common symptom. And so there are many, 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 many things that we need to do to dig into this. Just as an example, I'll share 8 things that we might need to look into. Okay. So part of the tenor of this conversation has been nutrition. And I absolutely would be looking at making sure that you have adequate water and that you're not having processed foods or sugar foods or fast foods. I would avoid soda pops. There's a lot of stuff that we would do as it relates to nutrition, because that can help improve cognition. I would need to look at your sleep hygiene. Are you getting 8 hours of restorative sleep? If you're not, then we need to do some work. I would look at your exercise regimen, right? Because exercise and movement improves cognition and slows brain volume loss. I would need to look at your recreational alcohol and drug use. We would need to look at which medicines you're taking. Are you on medicines like bladder medicines that are notorious for making people confused? Are you on pain and spasticity medicines that are making you confused? What is your disease modifying therapy? Is it working? Do you have accelerated brain volume loss? And can we use medicines to trick your brain into being more awake? So can we use things like Adderall and Provigil and Nuvigil to trick your brain to be more awake? So this is a really big portion of MS neurology, is managing energy levels. And it's extremely common in MS. Unfortunately, one of the hallmarks of long COVID in MS is fatigue. And so it's awful when someone who has baseline fatigue has more fatigue. It seems like just not fair, except it's real. And so digging in and looking for these various things that can help trick you into being more awake is very important.
Dr. Boster, we are coming to the end. Do you mind staying for a couple more minutes?
Yeah, let's do a couple more minutes. I can't go too long or I'll get in trouble, but I'll be happy to come back.
Okay, perfect. Margie, I see your hand is up. Can you hear us?
Yes, I was wondering, I put some of those questions in the chat on what's this new thing about the pap smears and the ectrum and the pap smear cells being irregular or different?
Margie, I have not seen that poster. I don't know that answer. Shame on me. So now you and David stumped me. This is completely embarrassing. No, I'm not familiar with that poster, so I can't answer you.
it was
Sorry.
just on that Ectrum thing that showed up on Facebook, so.
Yep.
That's
I was at Ectrum's, but I didn't see that poster, so I'm going to have to do some research. I don't know the answer.
Yeah, and I never had mono, so how did I get MS? And I know people at my school had it, but none of them were in my class.
Sometimes nature is too generous, don't you think?
Yeah, well, one woman told me she shared a small bedroom with her sister who got mono. She said, I never got mono. She never got MS, but I got MS.
Yep. Sometimes it's confusing to try to figure out. I agree.
But now if you're diagnosed late in life, does it mean that it'll go slower or will you get worse like everybody else?
So prognostically, if you are diagnosed after, if your symptom onset is after the age of 40, when 40 is not old, but that's the number. If you have symptom onset after the age of 40, that's a worse prognostic factor, because what we sometimes see is folks that are diagnosed a bit later tend to get worse a bit quicker. So the counterpoint is children with multiple sclerosis get worse slower, but because they developed MS at a very, very young age, they may end up disabled at a young chronologic age, just because they started so young.
Yeah, well, and then a lot of people want to know, did they really have it before?
Yeah, it's tricky to find out. It's not as if everyone gets an MRI when they're 18. And so oftentimes when someone presents at age 30 with neurological symptoms and we're doing a workup, it's the first time they've had their nervous system evaluated, which makes sense because they had no reason beforehand to do so. Great questions. Thank you. You're muted.
I don't know how that happened. I'm sorry.
Not at
Kristen
all.
is asking, I just secured grants for both of my drugs, Kesimpta and
Empira.
I go through this drill every January. When I have to take RMDs, I probably won't qualify. Do you see an end to this, or will we continue to jump through many hoops forever with insurance companies or big pharma?
So this is a great question, and it speaks to the healthcare system that we live in, which actually has nothing to do really with big pharma per se. So the way that we provide healthcare in the United States is unique. And it's mostly driven either by the government or by an employer. So we'll use an employer as an example. So you work at a store and the employer finds an insurance product and they buy the insurance product. They pay the insurance company a big chunk of money. And in exchange, the insurance company provides medical care. They pay for medical care for the covered lives of that employer. So if the employee then needs to go to the doctor, then the insurance money covers that, paid for by the employer. Now, the drugs are very expensive. So when you look at drugs like Kesimpta and Empira, you're talking about really large dollars. I mean, we're talking, like you could buy a house or you could buy these drugs. And the insurance company is not going to airy-fairy say, sure, honey, take it. They're going to do their diligence because of the price point of those drugs. And so each year, these drugs need to be prior authorized and pre-certed. And so is it going to stop? No, it'll never stop. And just to give you an example, so I run a standalone multiple sclerosis center in northern Columbus, Ohio, called the Boster Center for MS. And we have an infusion center where we administer MS drugs to patients. The first 2 weeks of January, I close my shop and all of my infusionists spend the whole 2 weeks on the phone with our hundreds and hundreds and hundreds of patients, pre-certing and prior authorizing every single infusion. It's got to start at the beginning of the year. So it's a facet of the system that we practice in. And so if you look at a different healthcare system, like in Canada, or say in France or in Saudi Arabia, the delivery of healthcare is rather different. And I think what you're going through is a reflection of the way that care is delivered and drugs are paid for.
Drew is asking, are there any meds being developed to ease the sensation of heat, or is there any progression in stem cell therapies for these symptoms?
So I'm not aware of stem cell therapies for specific symptoms. I'm aware of stem cell therapies that are looking at slowing MS. But if we look at the first question, are there medicines that help with heat sensitivity? So there is a medicine that's FDA approved to help with heat sensitivity called 4-aminopyridine, and the trade name is Ampyra. And Ampyra is a medicine that's taken twice a day, once in the morning, once in the evening, 12 hours apart. And about 1/3 of people that take it respond, and it buttresses against heat sensitivity. Now, that means that 2/3 of people don't respond, which stinks, and the drug can increase the risk of seizure threshold. So someone with a seizure, it's a no-no medicine. So what do you do in the instance of that? Well, there aren't other drugs that I'm aware of that can modulate heat that way. And so what we do instead is we do maneuvers to cool the body. So using cooling vests, for example, are an excellent way of trying to wick heat off the body so that you don't short circuit and you can handle the hot ambient temperatures.
Lewis is asking, is there anything new to help with drop foot and general leg weakening due to MS?
I would love for you to look up a device called the foot flexor, and flexor is spelled funny, like Flexr. So foot flexor. It's like a $30 device. It's a Velcro strap around your ankle with a bungee cord that ties to your shoelaces, and it just cocks your foot up. And you can push your foot down, it helps it pop back up. It's very inexpensive, and you can put it in your pocket, and you can throw it on when you're at the supermarket, and then you can take it back off when you get in your car. And that's a super cheap way of trying to deal with foot drop. And it's one of my faves.
Linda's asking, would you consider Mavenclad like an exit treatment plan for someone who has been on interferon for years? I heard this from another neurologist.
So there's a Canadian neurologist that kind of came up with this idea of using Mavenclad in someone who's like, say, like early mid 60s-ish, right? And he talked about it as an exit strategy. And when I first heard that, it really pissed me off and made me mad because it sounded as if he was done with the patient, like they're exiting, right? And I really didn't like that very much. And he said, no, that's not what I mean. What he meant was it's the last time that we intervene to adjust the immune system. Because you can give someone who's, say, 63, 64 Mavenclad, give it to them at 63, at 64, and then be done. And you may not need to treat them again. And I actually think that's amazing. And I've been doing that a lot recently in my clinic, where someone is getting really sick and tired of being on fill in the blank drug, and they're getting close to Medicare age, and we may give them Mavenclad, pop 1 year, pop another year, and then we're done. And I don't think of it as an exit because I'm not getting rid of the patient. They're still my patient. We're still doctoring together, but we're not using medicine. We've altered the immune response, and then we're going to hopefully coast over the next several years. And that's been really exciting, actually. So I love doing that, but I don't like the term exit strategy.
I'm going to just allow Deborah to talk, and then we will wrap it up because I know you have to go. Deborah, can you hear us?
Hey, Deborah.
Hey, can y'all hear me?
Yes, ma'am.
So I have a question or two. Not my original MRIs when I had my initial attack, but my subsequent MRIs, and I've had many. They always have language in it in the report saying chronic lacunar infarct, but yet my doctors and MS specialists say you have MS. Because if I look up lacunar infarct, that means a stroke. So then I'm like, oh, I had a stroke. They're like, no, you have MS.
So that's confusing, right? And
Yeah.
I'm going to make a couple comments. The patient should never, ever be in between two subspecialists because it sounds like we don't agree and we're arguing. So when the neuroradiologist and the neuroimmunologist have a scan and they look at it, you shouldn't have to listen to the discussion because it sounds like we're fighting. That's the first thing. And in that scenario, I want you to default to what the neurologist says, not because I'm a neurologist, but because they're the clinician who's seeing you. The radiologist is looking at a picture and they have one sentence, like 38-year-old woman with relapsing MS with numbness. That's all they know. And then they're looking at the scan, they're reading it. And they don't want to miss anything. So they're going to call everything they think they could see. They're not going to leave anything undiscussed. And sometimes you'll see a report that says unable to rule out neoplasm, which means cancer, right? And so the patient will say, oh my God, I have cancer. No, they don't. The radiologist was covering their tush. They were just saying, I can't tell you it's not cancer. It could be, because they don't want to commit. So the neurologist who has done the neuro exam and has looked in the backs of your eye, they know what you have. So when you have MS and you have inflammation, the white spot, it can be so intense that it eats away at the tissue. And it can cause what's called a black hole, which is exactly what it sounds like. It's a hole. In the world of stroke, that same hole is called a lagoon, which is Latin for a small lake, like a hole, right? A lagoon. And so if a stroke doctor looks at that hole, they're going to say that's a lacunar infarct. And if an MS doctor looks at it, they're going to look at it and say that's a black hole. And at the end of the day, it's not in your best interest to get in the middle of that argument. Now, let me say one other thing. When a doctor writes a report, it's written for a second doctor. It's not written for a patient. So the radiologist is not writing to you. They're not trying to tell you about your MRI. They're not trying to tell you that you may have had a small infarct or stroke. They're writing the neurologist. Now, some hospital administrator, like 10 or 15 years ago, must have fell and banged their head, and they thought they had a good idea that they would make all results available to patients. We'll just show you everything because we're completely transparent. See, look at all the things. Except they forgot that neuroradiologist and that neurologist went to school for 20 years to be able to read that scan. And they know what the report means. They had to take tests to understand the report. So then they give the report to you and they don't give you 20 years worth of school. They don't give you any school. You're literally using a dictionary to look up the words and trying to piece together. And that's not fair to you. That's rude, I think. So I dislike it when my patients are given a radiology report because they don't know the language. And oftentimes it just makes them scared. And so what I would much rather do is sit down with you and open the scan and show you. And I'll point at the black hole and I'll show you what it is. I think it's very challenging when a patient who's not medically savvy is given a medical report in a dictionary and they try to make heads or tails of it. And I always want you to go to your clinician to ask for translation.
I agree. There's so many people now that my parents even, they get reports and they freak out because they just see red lines next to things.
And
trained to think like that.
And it's not scary, but they weren't given the 20 years of school to know that. And so, on behalf of hospital systems throughout the United States, I apologize to you.
Thank you. Well, that wraps it up for this evening's webinar. If you missed any of this, it is available on our Facebook page, Multiple Sclerosis Foundation, through live stream. And it is also going to be available on our YouTube channel, Multiple Sclerosis Foundation, in a week or so. I want to thank everybody that attended and registered. We're so sorry we couldn't get to all your questions. And thank you so much, Dr. Boster, for taking the time out this evening. We really appreciate it.
It's my
pleasure.
Our next
webinar is going to be next Tuesday, January 24th at 6 p.m. with Oscar the MS Monkey to talk about how MS can affect your siblings as well. And thank you, everybody, again for attending. I hope everyone has a great night. Thank you again, Dr. Boster. I hope you guys have a wonderful evening.
It's my pleasure. Thank you so much for having me. And I want to thank the MS Foundation for creating this opportunity to talk to everyone tonight. Please look for me on the interwebs. You can find me on YouTube. My YouTube channel is Aaron Boster, MD. Come see me on Twitter and Facebook. Same thing, Aaron Boster, MD, even LinkedIn. So until my next YouTube video or live stream, be safe and take care, everyone. Have a great night.
Thank you.